Hello, everyone, and welcome to the next audio podcast in this series around on the LabZtorm effect v.2. This series is about the LabZtorm critique, and today's audio podcast is around the science behind nephrotoxicity. This is another collaborative audio podcast. Production in line with the ZtormLabostix production and a collaboration with the Renal Patient Support Group, or the RPSG. And I'm going to give an outline, an overview of the science behind nephrotoxicity by highlighting some works that have come out from the Renal Patient Support Group, and this work is kind of a summary, an overview of looking at nephrotoxicity in relating to immunosuppression, immunosuppression, where those who have transplants, who have transplanted organs, are on immunosuppression to prevent the transplant from rejecting, and thus also allowing a sort of a steady physiology between what would be referred to as foreign in relating to the physiology, foreign in relating to what would be referred to as normal physiology, and in line with immunology. So I'm going to highlight this in just a quick overview. So healthcare scientists, biomedical scientists, immunologists, and clinical scientists tend to collaborate best when there is a consensus in investigation around investigations on in and around different organs that might require transplantation, and in the workup for those organs to be transplanted in relating to laboratory tests and investigations. Now, in this context, there is where patients, where you have recipients and donors, where both of them would require a sort of number of serological investigations. In this context, the investigations I'm going to talk about or refer to are more around those who would require renal transplants or kidney transplants. And I'm going to highlight this from a pediatric nephrology perspective, in line with work that was formed nearly over 2 decades ago, in relating to some research that came out of based on some research, that was kind of preliminary basis of this work. So this is where collaborations are important, where in relating to healthcare and laboratory practice, are also successful when there is a determination to ensure safe efficacy of immunosuppression therapy with reduced side effects, and thus to identify best possible transplantation or best possible transplant and match for pediatric renal patients or pediatric nephrology patients, and to allow prolonged renal function. Serology laboratory focus on cross-matching and paneling techniques organized in laboratories. The important investigations for possible match-induced lymphocytotoxic tests and mixed lymphocytotoxic culture tests, and both are forms of tissue typing. Now, a clone match can't be established unless the pediatric recipient is a twin or has an identical twin, or in this case, when it's an identical twin, or there's a twin with the recipient, then basically it's referred to as an isograft. And in this case, where isografts are a premise, then in this context, they allow the best. They're referred to in terms of in relating to laboratory and serology tests and investigations. They are referred to as a very good cross-match tests and investigations, because the immunology would be very similar between donor and recipient. And now I'm going to highlight a little bit more about this, a little bit more about the tests and investigations. Now, so a clone match can't be established unless the pediatric recipient is a twin, and when isografts allow survival of kidney transplants 10 or 20 years post transplantation easily, or more, or quite easily, because of the serology, the ABO blood grouping and cross-matching tests and investigations, as well as the tissue typing. And so in this context, donors, and then following thereafter, donors such as those that are referred to as live donors from a living relative, also in relating to in some context in relating to isografts, and those who are from donor which is a twin, which would be a donor and a donor which is a twin from linked with a recipient, which is a twin. In that context, a live donor would have been known to take place, or in relating to transplantation. But just to also add, donors such as live or from the living, or from a living relative, and cadaveric, which refers to those who are from cadavers. In this context, recipient receives donor from someone who is pronounced as brainstem dead, have also been retrospectively appropriate. And in linking with tissue typing and cross-matching, in serological terminology and laboratory laboratory practice, there's something referred to as the major histocompatibility complex, and also the human leukocyte antigen. Now, the major histocompatibility complex, or MHC, and the human leukocyte antigen characteristics are not identical except in live donors and where there is a greater match complex. So the probability of donor and recipient in relating to cross-matching is very close is almost identical in relating to aspects that align to not just the serology, but some aspects around the genetics, and in keeping with the human leukocyte antigen. Now, cadaveric transplants show greatest risk of rejection, and in what has been studied and investigated, listeners, is that basically in some context, when when even from a twin or an isograft, if you have someone who's pronounced dead from an isograft, from an isograft perspective, what's not known is the post-transplant sort of survival or prognosis in that respect, because from a live donor related aspect, or living related, because the donor, the recipient are both from the living at that time, then generally speaking, the aspects that relate to not just the serology but the prognosis or the survival rate at that time would be would be pronounced as more probable and higher, would have, from a statistical perspective, would have a higher probability of survival. But from a cadaveric perspective, it might well be the same, but studies and investigations haven't delved into that too much. Haven't delved into or explored that as in an amount of detail. But generally speaking, from non-related live donor and non-related cadaveric donors, whether from an isograft perspective or non-isograft perspective, cadaveric transplants show greatest risk of rejection, but can be a decent match or cross match if carefully selected for post-transplantation, in relating to immunosuppression and anti-rejection anti-rejection treatment that individuals would have to sort of be prescribed. Would have to be prescribed. A sibling to sibling donor where HLA complement is similar should have can have 7 or more years prognosis, and there is literature out there, dear listeners, to actually kind of highlight the fact that that actually exists. Now, with greater differences of MHC complex and HLA characteristics between pediatric patients, the chance of prolonged functioning kidney transplant survival is reduced. And rejection of transplants occurs mainly through what's referred to as cytotoxic T cell effects, because what cytotoxic T cells do, or also abbreviated as cytotoxic CD8 cells, what happens is once a patient is transplanted or individual is transplanted, what happens is these cytotoxic T cells or CD8 cells, they migrate to cause a rejection episode to the foreign, to the organ, because as many would probably know, and in literature it has been highlighted, that generally the immune system would see, or open quote and close quote, would see the organ that's been transplanted as a foreign body. Now, rejection. So in context of this, rejection of transplants occurs mainly through CD8 T cell effects. Also relating to CD8 T cells are also referred to as lymphocytes or leukocytes. Immunosuppression and the probable nephrotoxic side effects also cause challenges, and this is nothing new. T cells aid in detection of antigens as well. There are these T cells that are referred to as CD4 T cells, which are known to be as CD4, as referred to as CD4 T cells are referred to as T helper cells, and in some regard, obviously CD4 T helper cells are there to actually almost supplement or propagate an initiation or an attack on the transplant that's been on an organ that's been transplanted. Thus, once that's happened, then CD8 goes also are lined up and also propagate a more vicious sort of attack on a transplant at that time. Now, what happens then is that uh, T cells apart from aiding in detection of antigens, and also can be uh, 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 in detection of antigens and cause a destruction on renal grafts. T helper cells sort of also help or support in appropriate recognition of complexes where the immune system is concerned. Thus, there will always be some form of rejection in transplanted in transplanted organs, because the for example, if there are sort of durations where the transplant recipient, for example, is not has long durations, for example, where they're not taking or not having their immunosuppression, for example, then basically the longer the duration in that regard, then the more likely or probable the transplant will reject. Now, in in line with this, I'm going to now talk a little bit about the nephrotoxicity side of things, and delve into this a bit more. Now, techniques for MHC typing have been advancing rapidly, from serological to molecular methods. These examinations are frequently costly, or have been known to be quite costly, and do not have a place in everyday clinical practice. Complementary to the MHC, to a major histocompatibility complex and technique, several other genetic indicators that may be linked with a variety of renal diseases or kidney diseases are being explored, but there are currently solely from this perspective, currently they're only being kind of implemented and explored from a research perspective. And research informs that kidneys from older donors, older, don- older donors, older donors into younger recipients should be avoided in some regard, and these kidneys should be given to age-matched recipients. However, that being said, there are laboratory assays that are out there that, for example, where older donors in that are being older donors that are being worked up with relating to serological tests and the major histocompatibility complex, and being explored for younger donors. For example, there are laboratory assays to actually identify if there really is a risk of transplant rejection, and worst case scenario, listeners, is that if a donor has been waiting for if a recipient has been waiting on the transplant list for a number of months or years, for example, then basically worst case scenario, some would say, is that the recipient would have an older matched donor in relation to transplantation, and their immunosuppression protocol, and what they would have would be on higher dose, for example. But that also has to be in keeping with the fact that if the tissue type, for example, is also a potential hindrance. And what I mean by tissue type is, for example, if it's not if it's not just a barrier or potential issue or barrier where age is an issue with relating to transplantation donor and recipient, but if that's not the if for example, if that's not the only barrier or hindrance, then it could also be an issue with relating to ethnicity, and also um, aspects that relate to other aspects that align to the serological tests. So, for example, again, the lymphocytotoxic T cell test, for example, if that shows preliminary on preliminary examination that there is a risk, then obviously uh, if there's a risk, but let's say, for example, there's a risk of going through that for a transplant to take place at that point, even if that's the case, but the clinicians and the surgical team, along with the laboratory team, can see that actually with an increase in immunosuppression, it could be viable, and provide the best chance of survival. Then it might well be it might well be the most viable way to actually help to actually ensure that the patients are going to get the best out of that transplant through, and the prognosis can still be very good. Now, I'm gonna in this context, obviously, then delving into the immunosuppression and nephrotoxicity side of things. Transplant pharmacotherapy has advanced, and new agents have been investigated and approved for use retrospectively. Solid organ transplant recipients depend on multiple immunosuppressive medication or drugs given in combination to prevent allograft transplant rejection. And these patients often require many other therapeutic agents to treat underlying illnesses or concurrent diseases, or even offset some complications that relate to other diseases. Whenever a new medication is administered or being prescribed to a transplant recipient, due to to a transplant recipient, there will always be this from a laboratory perspective, where different titers or levels or concentrations are monitored based on the toxicity levels that are deemed as safe enough that allowing the transplant prognosis to increase, but also toxic enough, or having enough toxicity, so that the immunosuppression that is administered falls within the therapeutic window, where the efficacy is high enough that is causing the immunosuppressive effect, but not causing toxic effects to actually cause renal or propagate renal insufficiency. So this can lead to, obviously, when this happens, this can lead to serious complications such as over immunosuppression and infection as well. Now, I'm going to say a few final things here, and then draw this audio podcast to a close, and that is to say that the pharmacokinetics of older immunosuppressive drugs, including cyclosporine, which is an immunosuppressive medication, immunosuppressive or anti-rejection treatment that dates back over 3 decades, versus tacrolimus or tacrolimus, and monoclonal antibody treatments such as mycophenolate, mofetil, and sirolimus or sirolimus are all complex, but also comparable. a narrow therapeutic index, unique to each patient, as well as variable absorption, distribution, and elimination are characteristics of these particular anti-rejection or immunosuppressive regimens. Therapeutic drug monitoring plays a fundamental role in helping clinicians and laboratory scientists in ensuring and helping to maintain blood and to ensure blood and plasma levels are maintained within safe and viable concentrations. Now, variation in concentrations outside the narrow, the what's also referred to as a sort of a narrow therapeutic range or therapeutic window can result in adverse clinical outcomes. Now, therapeutic drug monitoring also ensures that concentrations are not too high or not too low, and one of the sort of traditional techniques have been used is to ensure safe dosing as well. And from a toxicology perspective, is where high performance liquid chromatography is also used for therapeutic drug monitoring, and the active ingredient within the generic the generic name of these particular immunosuppressive agents. So, for example, HPLC or high performance liquid chromatography has been used for therapeutic drug monitoring of myclophenolic acid, which is the active metabolite for mycophenolate mofetil. And obviously, there's an active ingredient for cyclosporine, there's an active ingredient for tacrolimus, there's an active ingredient for sirolimus, there's an active ingredients for all the different another one is which I haven't named, but I'll say is another medication, another active another immunosuppressive regimen is also something which is quite not as used as not as used as much as it used to be. Is something referred to is an immunosuppressive regimen known as azathioprine. And again, azathioprine has an active ingredient as well. Now, and then now drawing this to a close, listeners, I'm going to say that the preferred modality for renal replacement is from a clinical perspective, is to most would be a renal transplantation in pediatrics, and its superiority in prolonging the longevity of pediatrics with end-stage renal disease, or ESRD. This is established and understood in literature. And in terms of quality of life, pediatric surveys indicate that renal transplantation is better than other forms of renal replacement therapy. And let's not forget and get it confused, dear listeners, that renal replacement therapy is also not restricted to hemodialysis, for example, or continuous ambulatory peritoneal dialysis or peritoneal dialysis. Kidney transplantation is also a form of renal replacement therapy. Now, apart from in line with that, immunosuppression or post-transplant is no longer one single regimen applicable to all patients. In the selection of the optimal immunosuppressive protocol, individual drug-related toxicity, recipient-related risk factors, as well as donor organ characteristics must all be considered. all immunosuppressants have therapeutic indices that can induce nephrotoxicity, and let's not forget that, and which also are difficult to distinguish in allograft rejection, and is still particularly a problem in the setting of renal transplantation. Although, having said that, there have been many advances made with relating to techniques from a surgical perspective, from a laboratory perspective, from a clinician or clinical medicine standpoint as well, minimizing the immunosuppression induced nephrotoxicity improves allograft survival. And allograft is another sort of fancy word, listeners, to say transplant. But however, to obtain a significant long-term improvement in allograft outcomes, it may be necessary to adopt new immunosuppressive regimens. And so that's why in the pharmaceutical industry, for example, there's lots of activity relating to different immunosuppressive regimens being trialed and tested, for example, and then challenges facing healthcare scientists, biomedical scientists, serologists, clinical scientists, as well, and clinicians, should now be focusing more on addressing the aspects that align to the equality, the educational support, and the burden of disease that can occur post-transplant. And obviously, in literature, generally speaking, listeners, there has been lots out there to say what's being done to and ensure an alleviation of burden post-transplant. But in some contexts, in this regard, is that the educational aspect of serology, laboratory tests and investigations, for example, they are not as apparent as perhaps should be as they should be as they could be, for example, in the amongst the public. And so therefore, in relating to healthcare aspects generally, where patients or individuals are being worked up for a transplant, for example, then the educational support aspect should be sort of linear, in line with aspects of healthcare. Because what's happened, or what is known, is that aspect is quite is a little bit fragmented. So what happens as soon as someone is has a transplant, or in the run-up to having a transplant, for example, the educational aspects are perhaps the most integrated at that point. But then after aspects that are aligned to transplant or transplant rejection, for example, then actually what happens is the educational support is more becomes more of a challenge to both from a clinical perspective, and also where patients look to identify or look to seek out in understanding or educational perspectives, and it can be challenging for them as well, so, on both sides. And so what should happen with these, with in relating to such topics, more of more of the sort of test the things that relate to test and investigation need to be or should be more accessible or kind of more viable approaches in the public domain. That's where I'm going to listen. I'm going to leave it like that for now. Then, dear listeners, and I will hope to catch you all on the next one. This has been another ZtormLabostix production and collaboration with the Renal Patient Support Group. This has been an audio podcast on the science behind nephrotoxicity, and this series is about the LabZtorm critique. Thank you for listening.